Good evening and welcome to our webinar this evening, the You, Me and the New Funding Agreement CPCF question and answer session with our panellists, our pharmacy contractors and also representatives of both the NPA and PSNC who are joining us this evening, and I thank you all for joining us. My name's Harpreet Chana. I'll be taking you through just a short introduction to start before we hand over to our panellists and then over to you for some live questions. I'd just like to apologise for the slightly late start. We had a slight technical issue, but all sorted now. Okay, so what we wanted to try and cover in the webinar, so this is number 5 of the funding webinar series that we have been doing since the beginning of March on funding and various other contractual matters. So they're all available on the NPA's website should you want to go back and access them on demand. This is number 5, so at the end of this particular webinar we're aiming for you to have just a view of top line changes under the new CPCF, some collective opinions from your colleagues of the new contract and how best to approach, how your colleagues have started to make some progress to embrace the new changes, and some of the things that you could be doing right now. So we propose this evening, I'm going to take you just through a very whistle-stop tour of some of the headlines of the CPCF changes. I'll then hand over to each panellist just to give their thoughts on what the contract means for them personally and what they've been focusing on so far in their own businesses, and then I'll hand over to you for some live questions. Questions can be typed into your questions box, so please do, as they're coming, feel free to type those into that box and I will pose those to the panellists once we get to that part of the webinar. Okay, so I just wanted to start with a quick poll. I wanted to ask all of the attendees, how many of you have read the 26-page CPCF document from the Department of Health and Social Care? If you could just answer this on the screen for us now, please. And I'll just give you a few seconds. Okay, so we've got votes coming in. So I've had okay, still a few people voting. It's 79%, so 79% of all attendees this evening have not read the CPCF document. I appreciate it is a long document, but the one thing that I think that we can advise you to do after the webinar this evening is to read through that document. The PSNC's Chief Exec has been, Simon Jukes, has been really clear that this is probably the most important document that any of us can read. It sets out really clearly what the department and the NHS want from our sector in the next 5 years. So we did send out a link, I think in one of the emails for this webinar, but post the webinar we'll also be sending out an email and we'll put a link to the document again so that you have it, or you can find it on Google if you just Google government DH CPCF and it should come up and take you straight there. Okay, so I don't propose to reproduce the document here as we obviously don't have that much time. I will say that the screen's not moving here. I will say that whilst I'm waiting for the next slide to come through, that PSNC did do a really good webinar once the announcement was made for the CPCF, which goes through all of the changes, and that's available on their website on demand. And they are also doing road shows up and down the country. So I went to one this weekend, and I would definitely recommend for any of you to try and attend one of those road shows. They are going on right up until the pharmacy show, and you get the opportunity to speak to the directors and the Chief Exec of PSNC and ask some of those questions live at the event. Okay, so just go back. Apologies. There we go. So just to give you some of those headline figures, so a 5-year deal has been secured, and it's securing £13 billion worth of funding over 5 years, set at a flat rate of 2.592 billion a year, which does include annual reviews. The funding settlement does involve the following headlines. So it's the removal of the establishment payment and MURs, addition of the Community Pharmacy Consultation Service, CPCS, changes to the quality payment scheme. It involves more engagement with PCNs locally. There's a focus on a prevention agenda, and also there's some terms of service changes that we all need to be aware of. When you look at the changes in entirety, and I don't propose you try and read all this now, this is just the headline figures. So I just wanted to try and highlight that there are a lot of changes to try and get your heads round. I know all the organisations are busy putting out guidance. NPA certainly are busy putting together resources and guidance for our members, some of which have come out already. What I will do here is just go through each section very quickly, again, just to give you those headlines in terms of context. So from a funding perspective, 2.592 billion across the 5 years. There will be a transition payment for the new CPCS service from October. We don't know what that level will be just yet. That's still being negotiated. We also know, whatever happens with the Brexit saga, that we also have the serious shortage protocol fee has been set at £5.35. As we go along the 5 years, that transition payment will potentially increase. There might be new services that are launched and will come through from that funding. Again, it's a little bit of an unknown at the moment. What the NPA have done is put together this quite nice infographic that shows the flow of money over the 5 years. And as you can see, that establishment payment will disappear as of 2020. MURs will be phased out by 2021, and you can see that those new services and that transition payment, that block does increase over the 5 years. So it's just giving you a bit of a flavour in terms of where the money is flowing over the 5-year settlement. In terms of services, MURs for this year will be capped at 250. Only 200 will be allowed from April to September, the first half of this year. PCN pharmacists will start to conduct structured medication reviews. There'll be the rollout of the new Community Pharmacy Consultation Service, and there'll be a hepatitis C service in this first year. As we go along the 5 years, you can see that there's the MURs will be capped at 100 for the next financial year, and then will eventually be phased out. There will be introduction of a new medicines reconciliation service. There'll be a palliative care medicine service, and the scope of NMS is potentially going to be expanded as well. So the CPCS, this is essentially the NHS 111 referral service, which will be introduced in October this year. We do have Mark Burden with us here, who is based in the North East, which obviously led the pilots of DMERS, which this service has been based on. So I'm sure he'll be able to bring some of his expertise and experience of that service here. The fee for the service will be £14 per intervention. There will be a transition payment available for CPCS, but you must register by the 1st of December in order to get that service, to get that £900 fee. It will drop to £600 if you don't do it by the 1st of December, but you must do it by the 15th of January next year in order to get that fee. And as details are released in terms of how you can register for these fees, we will of course make that available to members. The referral service will evolve over the 5 years from just being an NHS 1 referral service to a GP referral service, and hopefully urgent treatment and A&E referrals too. From a public health point of view, the hepatitis C testing service will just be a short service for needle and syringe patients from 2019 to 21. Healthy Living Pharmacy Level 1 status will become mandatory, and then coming towards the end of the 5 years, we'll be more involved in blood pressure and atrial fibrillation case finding, stop smoking referrals, early cancer diagnosis, and a possible contraception service, amongst others. Quality payments. Now, there's quite a number of changes involved in the quality payment service. First and foremost, in that the criteria will change and are being bundled together as a domain criteria. There will be a review period instead of a review date, which will be next February. You will be able to claim an advance aspiration payment of up to 70% of QPS earnings from 2018 to 2019. Again, details of that haven't been made clear yet, but as soon as they do, we will share those. The biggest two things that we can advise you when it comes to QPS in terms of what you can do right now: make sure that you are registered for the Manage Your Service application through the NHS BSA website, because without that you won't be able to claim for the payment and for your aspiration payment. And you also must make sure that the NHS website gateway and the Directory of Service Quality criterion have been met by the 30th of November this year, because you will not be able to have any payment without that. So they are two very critical things that you must make sure that you have done now. Within the PQS, there will be more engagement expected with PCNs and more involvement in prescribing safety and diabetes patient checks, with some other enhancements, if you see, in terms of suicide prevention training, inhaler technique, and various others, and details of those will be confirmed as they are negotiated. Oh, skipped one. Regulation changes. So there will be new terms of service requirements from the 1st of April for NHS Mail, Summary Care Records Access, NHS 111 Directory of Services, NHS UK Pharmacy Profile Updating, and all pharmacies must be able to use EPS. So that'll be from April next year. And we understand from Gordon Hockey at PSNC that there will be potential other changes coming down the pipeline to enable mergers, closures, hub and spoke, original pack dispensing, and powers to empower technicians. So that kind of really gives you the headlines from the CPCF agreement. What I would like to do now is pass over to our panelists, and if we can go to them one at a time. So I'm going to propose that we start with Rena. Rena, if you can just give us a quick introduction and some of your comments and thoughts on the contract and what you're doing right now to prepare for those changes.
Hi, Harpreet. Yes, my name is Rena. I'm an independent contractor at a pharmacy in Sutton in Surrey, and I'm also an NPA board member. I think first and foremost, what I've been doing is sitting down and reading the 26-page document. It is absolutely essential that people do this. Read it, understand what it means for you and your business, and read between the lines to see where NHS England and Department of Health really see pharmacy going over the next 5 years. And I can't stress that enough. Reading between the lines is so important. So I've done that, and I guess for me there are kind of three things that stand out. There are a few things that upset me, there are a few things that frustrate me, and there are a few things I'm excited about. So I guess starting with the things that are frustrating me are the unknowns within the contract. You know, there are many. We don't know how the transition payments will be kind of phased out, and how they will, not phased in, I mean, and how we'll be getting those and how the distribution will work. We don't know about the new services. Will it be national services? Will it just be local pilots? You know, will I be hard done by if my area doesn't get chosen for one of these new service pilots? So those are the things that kind of frustrating me a little bit, the unknowns. What I'm upset about is losing the establishment payment. I guess it's something we knew that was going to happen, but in all of our minds as contractors, that establishment payment just kind of keeps you going. You know, for my business, it pays for my utility bills and all those things that help me to have an establishment. And so that is very upsetting to lose that kind of core money that we were getting. And actually losing the MURs, they're being phased out, obviously. But actually MURs have allowed us to have a new relationship with patients, and actually create a patient expectation as well, that we will support people with their medication, and we will support people with long-term conditions. And so I'm quite sad about losing the MURs in a sense, because I hope people don't start to not offer that service and that patient-centered care that we were giving when we conducted an MUR. I've got so many patients who just walk into the pharmacy and say, can we have a quick word in the room? You know, will they be able to do that? Will we be able to offer that? And that's something I'm kind of a little bit upset about. MURs also helped us to build relationships with our GPs and practice nurses as well, because of the feedback we were able to give them on what their patients were actually doing and taking. And so we'll lose that element of it as well, which is upsetting. But at the same time, I am excited about certain things. So the CPCS is a very exciting development. I absolutely believe pharmacy has a massive role to play in urgent care, and it's really nice to see NHS England and Department of Health creating the CPCS and allowing it to be rolled out nationally, so that we can really support the Pharmacy First message, which I think is really, really exciting. Also really keen to work with PCNs, because all of us work within our communities really closely, and I think supporting that population health in a joined up way with people in our primary care network will be a really, really interesting way of working, and really exciting. So for me, I've kind of created a plan for next year. How do I recoup the money I'm going to lose from phasing out of MURs and establishment payments? How do I set my team up so that we are ready to provide services, as opposed to right now where we're core function is dispensing? And those are the sort of things that are kind of going through my mind at the moment.
Brilliant, thanks, Rena. And I suppose I wanted to just pick up one comment you made there around MURs have allowed you to have those additional conversations with GPs and about their patients, and I just wonder, is there scope now to try and increase that conversation, because there is that focus in terms of working locally within the PCNs and some of the other services that might be coming down the pipeline, that you kind of laid that foundation, and it's important to keep that dialogue going, presumably with your practice.
Absolutely, I think the PCN work and working with our PCNs, we could maybe incorporate some of the things we've lost through MURs, and I think there is a need out there. And community pharmacists do have a role to play in long-term conditions, and I'm sure our GP colleagues and practice nurses need the support and help patients with that as well locally.
Brilliant, thank you very much, Rena. I'm going to bring in Gary Myers now, who is on the negotiating team of PSNC, as well as being a pharmacy contractor. So Gary, if you can give us your thoughts and comments on the contract and things that you're doing right now in order to prepare to deliver.
Well, the first thing I'm doing, by a popular request from some of my colleagues on the committee, is tomorrow I've actually got my induction for the independent prescribing course, because I actually think that that's the future. Everything I've seen and heard during the negotiations have convinced me of two important, fairly hard messages for pharmacy contractors and community pharmacists generally, which is that the government, and particularly the Treasury, don't really value dispensing. They consider it purely transactional. They consider it something that can easily be automated. They consider it something that doesn't make best use out of our clinical skills. The other thing that they don't value is procurement. I'm very often told by community pharmacists that they're important, that they view the procurement role as actually being vital in terms of delivering value for the NHS. But from the NHS's perspective, and especially the Treasury, so far as they're concerned, that again is something that can be consolidated and automated and done elsewhere, possibly more effectively with greater economies of scale. So those are two hard messages for pharmacy contractors. What the NHS values is the untapped clinical skills of community pharmacies and their teams. And that's one of the reasons that we've actually been given this lifeline. And believe me, it is a lifeline. One of the things that actually came across really strongly in the negotiations was that there is this theory that was expressed by one of the lead people from NHS England about the counterfactual. What I mean by that is the alternative. If, for example, we'd actually walked away from these negotiations, two things are almost certain to have happened. The first is that we were actually staring another funding cut in the face. We know that because the Treasury had a 3-year comprehensive spending review, which included the 18-19 period to end of March just ended, at which point the intention was to cut the pharmacy budget by another 32 to 33 million pounds. The original intention in the pharmacy cuts was to reduce the global sum by 240 million. In the end, we've ended up with a cut of 208 million. So there was a further cut in the offering this last year of another 32 million pounds. Now, we know that, but we've got proof of that from papers that were released by NHS England, a board discussion, where largely NHS England sort of blamed the Department of Health for not securing additional savings in the 18-19 fiscal year. And that's the cut that the department ended up not implementing. The other thing we know is that the MUR budget, it's been the intention of NHS England for some time to decommission MURs. The fact is they do not consider them good value. Now, when you actually sit down and think about it, The cost per MUR of £28 is something that can easily be done a lot less expensively by a clinical pharmacist with full access to the GP clinical system. And if you actually equate that to the amount of money that a GP gets, the cost of an MUR is actually, even by a GP, a salaried or even a partner doctor, the cost of MURs is actually greater than it is for a GP to do that work. So from a treasury perspective, there is absolutely no doubt that that's not good value. I might add that the fee per £14, we actually made some rigorous attempts to justify a higher fee on the basis of the cost of us delivering that intervention. And actually, we couldn't get the numbers higher than £14. And we know for a fact that Treasury analysts were all over this. And it's really important to them. And the reason for that is because it sets the benchmark for the CPCS, and especially when we start receiving GP referrals, when the numbers are likely to rise exponentially. Because obviously the Treasury needed to be satisfied that that is a cost-effective intervention for us to make. Whether we like it or not, their job is to actually protect or deliver value for taxpayers, and that's their primary aim. And in the event of obviously us doing a lot more of those interventions, they needed to ensure that the £14 fee represents good value for taxpayers, right? So, and obviously, the other message, hard message for contractors is you need to upskill yourselves. Because if we start actually triaging patients and seeing patients that would have otherwise gone to the GP, it is critical that we're able to demonstrate that we're up to the task. And that means being able to detect and triage serious conditions, spot the red flags so that they receive appropriate care, whilst at the same time handling those patients in a community pharmacy that can be safely treated by us. And this is all about expanding capacity for the NHS. But in addition, and critically, as Simon Dukes actually puts it quite effectively in his video, which has been shown at the roadshows, it gives us leverage. Because when we sit down in front of the NHS, bearing in mind the NHS doesn't value the core dispensing service or drug procurement for the reasons I've just mentioned, we have nothing to bargain with. If we deliver the community pharmacy consultation service effectively, that will give me leverage to cut a better deal with our paymasters. And bear in mind that our customer is the NHS, not the patient. It's the NHS that hold all the cards and they hold all the funding. If we're unable to persuade them that we can deliver this service effectively, safely, and deliver value for taxpayers at the same time, then we may be condemned to what was euphemistically termed the counterfactual. In other words, further funding cuts and the complete loss of any ability to deliver clinical services. So we know, for example, that the original intention was not for the NHS to reinvest MUR savings in community pharmacy. It was to put that money into primary care networks. So that not only would we have faced a funding cut of £32 million, but we're also facing the loss of all the MUR funding. What this deal does, it actually puts that money back into the global sum. We've saved it. So whilst it's not a particularly good deal, so far as I'm concerned, as one of the negotiators, I also know that the counterfactual, the alternative, was much, much worse. And so that's probably one of the reasons, and I know my colleagues on the committee actually understand this, is the reason that we actually accepted a deal which was far from perfect, and it represents some huge challenges for us. But in a scenario where we've little bargaining power, and we've got a government that understands that what we do at the moment to them has limited value, then we've not much choice. And at the end of the day, if that turns out to be the best deal available for contractors, then that's the best deal available. And that's one of the reasons I voted to accept this. That said, I do actually see it as a huge opportunity for us, because I've long believed that the future of community pharmacy is not about dispensing. It's more about the delivery of clinical care, which is the reason I'm actually doing the prescribing course myself, and I'm currently investing in upskilling all my technicians. The only way this system works is for community pharmacists to invest heavily in skill mix, so that I don't any longer need to put labels on boxes or check prescriptions when it can be done just as effectively by an ACT and a bunch of dispensers, and that frees me up to spend time in a consultation room doing what the NHS wants, which is for us to see patients. So obviously we've invested a lot of time in developing our PQS offering, and I've basically appointed somebody in my own business to oversee all that work with a suitable incentive so that I see that it gets done, so that we deliver maximum points, and we're currently working on it now. All of our pharmacies are already registered with MYS, because the NHS BSA will move towards electronic claims for virtually everything, whether it be the FP34C or flu vaccination claims or PQS. It's all going to be done online because it's more straightforward. So that's what we've been doing. We're obviously focusing on trying to upskill everybody. And I'm also advising our pharmacists to do more consultation skills training and take advantage of all the resources that CPPE have got. That's it.
Okay. Thank you very much, Gary, for your comprehensive answer and for your honesty with some of those. And I'm sure that you've answered probably some of the questions that our audience has already. But if you have any comments or questions based on what Gary has said, in particularly around negotiating the contract, please do pop them in the questions box, and I will put them to the panelists once we have finished their own thoughts and the answers to the questions I put them. So I'm going to move on now to Andrew next, please.
Hi everybody, so I'm Andrew Lane. I practice in Gloucestershire. I'm also chair of Gloucestershire Local Pharmaceutical Committee, and I've been sort of asked to talk about PCNs and what's happening in our locality and what is happening in everybody's locality. I think it's down to your local LPCs to inform you what's going on locally, and our LPC met last week. We had it facilitated by Pharma. They came in and worked out that across our PCN we need to get busy with basically introducing ourselves to the local structures that have recently formed around clinical directors who were put in post just over a couple of months ago. So we mapped out in Gloucestershire, it's one ICS, integrated care system, and there are 15 PCNs just in Gloucestershire alone. So that's quite a task when there's only 105 contractors, and we're all limited to what we can give in terms of time and effort. But we felt that over the next year, we need to get to actually learn what the clinical priorities are going to be for the PCNs. So you kind of need to ask your LPC, what are they doing to support you in making sure there's a plan around PCN engagement? So very briefly, we've decided that, you're in the queue for the GP, you're number 42 in the queue on the call. There's not much point in trying to talk to the GPs about this. There's a lot of egos in that PCN between the GPs alone. So it's better just to sort of try and go in at a low level, build relationships if they're not already there, particularly with practice pharmacists. They're going to be our key to driving some of the relationships going forward. And we've identified key people in our contractor base who can form relationships with local GP practice pharmacists and start building from there. Even basic stuff like having conversations around ERD. So as Gary mentioned, it's all going digital, and ERD variability, as we've seen nationwide, is massive. So you've got some surgeries that aren't doing it at all. Some surgeries are doing sort of 70%, but the average I think is something like 35% nationally. It might be lower than that on ERD. And what I mean by that is, as Gary's alluded to, we're not going to be paid for volume anymore. We're going to be paid for service. And therefore, if we can spend the next year in making sure we're more efficient and we release capacity in what we can do, then we're only going to do that by actually cutting down on the volume. And if we cut down on the volume, we'll release capacity to do more services. And electronic repeat dispensing is just one box that the doctors can tick for us. They haven't been able to do it. And I think if you're able to build relationships with your practice teams, the practice pharmacist support people will do that. That's their remit. and you build relationships around that. They will do something for you. You can then do something for them. And I think with the referral scheme that's coming, there's a lot of work around the pilots on GP referrals happening. So we're in a pilot at the moment on GP referral that just is starting at the beginning of next week. We're effectively seeing a training session for the GP staff, and they relish this opportunity. No one's trained them in this before, it would appear, bizarrely enough. But I think you really need to find out what your LPC is doing in this area, because it's a minefield, it's relationship driven, there's a lot of egos out there, and I think we've just got to cut through this, because that year will go very, very quickly. And unless we max out the opportunity to give ourselves some space, then we, as Gary says, we won't be ready for the new clinical agenda. So the clock's starting to tick. Chase your LPC. There's got to be a plat, and I think pharma are more than happy to support some of this. So like I said, make sure you're sweating your LPC. That's probably about it. I'll take questions from anyone on PCN and integration across the next half hour. Thanks, Harpreet.
Thanks, Andrew. And last but by no means least, Mark, I'm going to hand over to you.
Thank you, Harpreet. So major focus of these latest revisions to the contract has been urgent care, and as Harpreet said earlier, what's now the CPCS started in the Northeast, where I'm based myself. So looking at this whole thing in its totality, I see this as a transition over 5 years. There's not an awful lot of things that are necessarily new to us. We've been expecting them for some time, long since before the announcement on the contract. So we know that the NHS is under enormous pressure. There aren't enough GPs. The NHS is strapped for cash. So what do we do about it? Well, 5 things. First of all, much of this has been picked up already by the other 3 speakers, but just to summarize. So first thing is workforce. This 5 years gives us time to, if we haven't already, to plan our workforce. So 4 different types. So support staff, getting the most we can from the people who are on the shop floor, who are seeing people day in, day out all the time, upskilling them. Secondly, pharmacy technicians, working with technicians to make sure that they are capable of running the dispensaries that we operate, freeing up the pharmacists. The pharmacists themselves have to be readily accessible. They have to be at the cold face, pressing the flesh, doing all the clinical work that the NHS needs of them. So we need to make sure that they have the proper skills and everything that they need. Training. So many of us train pharmacy technicians. We train pharmacists, and that has to continue. So our pre-reg staff. So that's on workforce. Secondly, expanding our scope of practice. So you hear about this term scope of practice and extending or using a full scope of practice. You hear this all around the world. So what is it? It's pharmacists and pharmacy teams working flat out to the full potential that they have. In the first instance, much of that might be in the private service remit. So like Gary here, and I was one of them who encouraged them to do this, we need to think about prescribing, because being able to prescribe in an independent way opens up an enormous amount of things that we can do. So if we can demonstrate that privately, and maybe at a small scale, there's no reason that, as Andrew says, through the primary care networks, that we can't be paid for some of these things. So, as Gary himself works with GPs locally, we've got laptops from our local GPs that trust us to manage long-term conditions for them and take up some of the queries that the GPs haven't got time to do. There's vaccinations, there's clinical research, there's a whole range of things that we can be doing. Thirdly is premises. So are our premises up to spec? Do our consultation rooms meet the expectations of patients? So there's some work to do there. That's the third thing. Fourthly, marketing what we do. And many of us have websites that we make, we make some sort of use of. The people are moving towards an online offering. The key for us as independents is linking that online presence with the premises. So you've got this kind of online pharmacy premises model. The pharmacy 2Us of this world and the online traders, they are internet, distance selling. They haven't got the ability to see patients when they need to see them. That's something that is in the independent sector. We have massive opportunities to exploit. We have the staff, we have our premises. So making our premises inviting is absolutely key, and kind of marketing what we do. Finally, IT. So there are efficiencies, and it might not be moving to a full hub and spoke. It might just be doing little things that enable us to do things more efficiently. So Farm Outcomes as a platform and Sonar and some of the other systems have allowed us to become more efficient. We know the services that we provided. We have claimed them in a timely way. We know when those claims have been paid for. The other options are pro delivery, managing our deliveries, rules-based ordering platforms, patient-facing apps, doing things more smartly through the better use of IT. And I don't mean moving down the way of necessarily a hub and spoke. Maybe that's something that will come in time. Maybe it won't be. But that's just my kind of top line things. I'm conscious of time to pass back to Harpreet for questions.
Thank you very much, Mark, and you've given some really good food for thought and some tips in terms of things that I'm sure our members could be doing right now to think about being prepared for the changes. So thank you very much for that. I'm going to like to open the floor up to questions. We have had some questions come through already, so I will put those out now. I'm going to start with, so we have had a question around something around whether this deal is better for the big boys or for the independents rather than the small independents. Now, as you all represent smaller independents, I think this is a really interesting question to get your thoughts and comments from. Does this contract favour the big boys over the small independents? I'll start with you, Gary.
Absolutely not. I've had it said by officials within NHS England to me privately that they, as far as they were concerned, they see this as an opportunity for independence more than it is for the multiples. Why do I say that? Because it's all about engagement with practices locally. Obviously, if you are a pharmacist that tends to move around a lot, as you know, as is often the case with pharmacists that work for the larger multiples, especially the big corporates, it's difficult for you to provide effective longitudinal care to your patients and also build those relationships with the GPs. So I've basically been nominated to be a lead in 2 primary care networks where we operate, and I'm on first name terms with one of the GPs in the practice I deal with. And I spoke to him the other day about a patient that got some issues, some real issues. And he's the lead GP, the clinical director for the new primary care network. And I've already got a really good relationship with him. I think it's also worth mentioning that independents tend to be able to cooperate better at a local level. Now, that's not always the case, but I've actually got a number of independents operating near me, and I actually get on really well with them. That although there is some element of competition between community pharmacies, I think where independents are concerned, there's a greater capacity for them to actually come together and work collaboratively across a local network. And that's actually something the NHS really values. Now, Ed Waller, one of the lead people in NHS England, has said that's going to be really uncomfortable for community pharmacies. But you know what? We're just going to have to suck it up. And it's no different to the circumstances that general practices actually face themselves within primary care networks. Some GPs don't actually get on with each other very well at a local level. And there've been a number of scraps. I know that from my work with the primary care network already, between local GPs arguing about this and that. And it's going to be the same for community pharmacies. But we've got to get on with it. We've got to set aside our clamour for green pieces of paper and start to come together to provide care effectively across a particular neighbourhood or locality. And I see that as a big opportunity for independents. And I think that the current corporate structures of the larger multiples will make it very, very difficult for them to adapt to that kind of environment.
Yeah, anything that adds, sorry, Harpreet, anything that adds,
that's fine.
Yeah, any complexity that's added to the system is really difficult for the corporates to operationalize. Whereas frankly, our staff are more likely to do things because they're working with the actual owner of the business and the practitioner, and we are hands-on. This is not the case, as we know, with the multiples. So anything more complex, better for us, less so for them. We are more nimble on the ground than they are.
Thank you. Is there anything you want to add, Rena?
Yeah, I was going to say, as independents, we are more agile and nimble, so I think we've got that in our favour. I think one of the things where I wish I was a big boy or big girl is the PQS and the sheer amount of work that has to be done by each of us. And as independents, we're sitting there in our pharmacies reading through these emails that keep coming through daily, trying to meet all these audits and various different kind of elements of it all. And that's where I wish I had a head office that could just, tell me what to do in brief, or do it for me. And that's where obviously the big boys have got the advantages against us. And I think that's something that really needs to be considered and factored in, because we are drowning in paperwork, drowning in workload. And as an independent, that's a struggle for us.
Just on that point, actually, Rena, I'm going to just move to another question that we've had around, as an independent, my current prescription volume is on the increase. I do the occasional extra service now. How can I manage my day to fit in the future services without employing a second pharmacist?
Really difficult question, actually, but I think Gary has said it. There is, no money in dispensing, and actually some of us are going to need to think about where we spend our time and where we allocate our staff. How much time are we giving to dispensing that is necessary, and how much of it is unnecessary? And thinking about, I can't afford a robot, but are there elements of the dispensing process that could be done better by skilled staff? And I think all of us really need to think about the time and the money we're putting to the different things and where the funding is coming from. And that's where I meant about reading between the lines of the CPCF contract. It's really, really important people understand where the money will be in the future, and where you need to invest your time and invest in yourself to kind of get there. But I can totally sympathise with that contractor, because I think we're all in the same boat. We're trying to do the day job, but actually many of us aren't realising the day job is changing.
Yeah, so there's lots we know through the judicial review, and whether you think it's a good thing or a bad thing, we've found a lot of information out through that process, as well as through the negotiations that are still ongoing. And we know that the Treasury is the element of government that doesn't value dispensing, because people keep telling them, whoever that might be, people keep telling them that you can dispense things cheaper using robots and in hubs. Now, whether that's right or wrong, that's what they think. The other point is that prescription volumes are actually decreasing. So I can remember in this area in the northeast, Sunderland being plus 11% volume growth year on year. That doesn't happen now. It's kind of flat. And with deprescribing, it's probably going to drop below into negative territory. So relying on the prescription volume that's done us well in the past is not a sensible option going forward. So we need to look at different metrics. It's not necessarily prescription volume that we're chasing. I mean, there was a comment there, Ian mentioned something, about prescription volume, that question. What I'm finding is that some of our multiple colleagues who are going to things like hub and spoke are shedding patients left, right and centre because the service they're giving is rubbish, and they just can't operationalise it properly. So people are coming to us in droves. Our nominations are going up, our prescription volume's going up. So, patients will vote with their feet, I think, and if they're not getting the service they want, they'll come to the independents. Now, whether we base our funding on prescription volume or patient volume is another thing, but there's still, I think somebody mentioned it earlier on, these negotiations were undertaken in a ridiculously tight timescale. There's no way anybody would choose to do anything in such a short timescale. So consequently, there's lots of things that aren't quite there yet. One of them is how pharmacies are paid for. Quality, we know, is something that the government like. They're really keen on the quality payments. Now the pharmacy quality scheme, they like that. They don't like clusters. We know that for a fact. They've said it in the deal document. As we said in the poll at the start, we'd commend that to everybody to have a look at that. It mentions specifically around clustering. They don't like that. But it's such a difficult one because we're all used, and the system at the minute is around prescription volume. In due course, and I'm sure Gary can say a lot more about this, in due course we have to shift away from that, and whether that's some sort of a capitation based model where more like the GPs, or it's something different altogether. I don't know. We haven't been through that process yet, but that's to come.
Yeah, before you come in, Gary, before you come in, Gary, I know you're going to have an answer to that, and sorry to just cut in there. I think, can I ask you, when you answer or respond to Mark's answer there, we've had quite a few comments around why is it that we have chosen this deal, and why did we not push back further? Why have we not recognised the skills of pharmacy, and that the deal may not be reflective of current costs of doing business? And there's been quite a few comments on that. So would it be possible just to try and address some of that?
Absolutely. Right. So for the record, we did try to actually put more money into the contract global sum. I've already indicated that so far as the Treasury is concerned, this deal wasn't something they wanted. The Treasury wanted to cut funding further, and it wanted to strip out clinical services and move them into primary care networks. It's not that long ago where a senior official at NHS England told us they were proposing to offer pharmacists what we call a supply-only contract. A supply-only contract with an intention to deploy hub and spoke, large scale, and move a lot of prescription volume online. Now that would have actually spelt the end of independent community pharmacy, because it would have been all about scale, with all the clinical stuff being handled by PCN-based clinical pharmacists. So whatever clinical role we've currently got, the counterfactual, the alternative, if I banged the table and walked out of the negotiations, and believe me, on several occasions I felt like it, would have been to sell our entire independent sector down the river. And somebody said, I think earlier in one of the questions, that this deal favours multiples. Actually, it doesn't. Because we've actually kept the deal as it is and given us a lifeline to deliver and demonstrate that we can deliver clinical services, we've actually given independent community pharmacy a future. In a scenario where it's a supply-only contract, where it's all about scale and volume, I'll leave the watchers of this video to determine whether that would have been good for independents or whether or not it would have been better for the multiples. I know where my opinion lies, right? At the same time, I think it's also worth reiterating the point that they value community pharmacy, they value bricks and mortar pharmacies, right? The reason they don't value clusters is dead simple. If you've got two pharmacies dispensing 2,000 items apiece near to each other, or whatever it is, or several pharmacies doing those sorts of low volumes, they found with general practice that a general practice, a single-handed small GP, cannot deliver the range of services that they currently want. And they've therefore allowed those practices to merge and coalesce, and smaller practices are withered on the vine with the lists dispersed to other larger practices. They see community pharmacy as no different. Why would they actually treat us any different to general practice? Why is a smaller pharmacy entitled to survive if a small general practice isn't? And that's a hard question. But if you think about it, if you are a pharmacist working in a low volume, because you've actually got a low cohort of patients, a low volume pharmacy, then you will de facto spend most of your time assembling prescriptions, putting labels on boxes, and then handing out to patients. So far as the Treasury is concerned, that's not good value for taxpayers. They want pharmacists to spend the time seeing patients and let someone else do the dispensing who's competent to do it and can do it safely, but is a lot less expensive for taxpayers. So in that kind of scenario, if we've got 2 or 3 pharmacies all dispensing low volumes, the best solution for the Treasury, so far as they're concerned, bear in mind, they hold all the cards. This is what someone once called a monopsony, a monopoly payer, right? We have no bargaining power. And in that scenario, the best option for taxpayers is for the 2 or 3 pharmacies to merge, so they're dispensing more volume. And then that means that that pharmacist that's remaining in those, what was 3 business, now consolidated into 1, can therefore employ lower qualified staff to do the dispensing and free up that pharmacist to spend time actually seeing patients. And if you sit down and think about it, set aside your own prejudices and just consider it from their perspective, right? Clustering does not make sense. So long as you can protect access to services, and you've got a smaller number of pharmacies operating at greater scale and volume, that allows you to provide more services more cost effectively, and it frees up the pharmacists using skill mix to deliver care to patients, as opposed to the wasteful approach, which is the way the Treasury sees it, of paying pharmacists to put labels on boxes and assemble prescriptions. So that's a hard message for me to explain to people, but the alternative was disaster for independent community pharmacies, so far as I saw it. So I make no apologies for having accepted the deal, because I was clear about what the alternatives are. And I might add that senior officials at the Department of Health made it also clear to us that this deal from their perspective was also a compromise. There were individuals in government that wanted to cut the budget. And so what we've ended up with is a flat cash deal was a compromise across government.
Okay, thank you for that, Gary. I'm going to move on to Andrew. If I can ask you a question around that we've had around what about pharmacy supporting the wider society and contributing to social care? Pharmacy staff are critical in recognising and referring to social services and raising concerns, i.e. the job of social services. We should be able to get funding for this, and maybe the practice payment should be revamped to incorporate this or brought back.
Okay, yeah, I saw that one from Nikesh, and I thought, you know, we've got a system where in Wales and in Scotland, the chief pharmaceutical officers value social capital. They've said this several times. So Rosemary Parr in Scotland and Andrew Evans in Wales have both used the term social capital. And I think, you know, Nikesh makes a good point here. I don't think we've leveraged our capacity to support the system. Well, actually, the PCN network allows us to make our case for supporting that system. So I think you're right. You know, we should be able to leverage our ability to squeeze funding for what we can achieve as sometimes the only clinical provider in a community left when the GPs are up sticks to the leafy suburbs, and there's value in that. And I'm a firm believer in, you know, the £4.5 billion that's been pushed into PCNs to support the 7 GP DESIs. You know, some of that money needs, sorry, some of the services need our support for the system to deliver what it's set out to deliver. And it's not just about the NHS funding side of the coin here. I think if we look at the funding that's going into PCNs, that £4.5 billion is a heck of a lot of money. And when you start looking at the first movers who will start developing services around social care platforms, clinics, Rena is an IP. And I think, you know, I heard a statistic which worried me the other day, that there's a massive volume of independent prescribers who are out there in the locum pool. So we get a lot of our locums from Birmingham. And I think it was something like 60% of the recognised locums in the Birmingham area are IP qualified. But because they're not confident about joining the system, or don't actually have an opportunity to join the system because they're in the local pool, I think it's incumbent on us in community pharmacy to engage with the IPs out there and work with them on developing services that actually the local patients need. As Gary, I think, has said, the number of GPs is declining. The problem is there aren't enough clinical service providers in the system, and actually, instead of sticking labels on boxes, we are the answer to that clinical service provision, and we should be paid handsomely for providing that service. And that goes to that social prescribing support as well. I think in the next 2 years, social prescribing and pharmacists in GP surgeries is where the funding is going to go. So, you know, we're fairly pole position to sort of grab some of that funding. But I think that's what I want the MPA to help support the pathways to allow our members to be there at the front of being able to provide some of those clinical services. So I hope that answers Nikesh's question.
Thanks, Andrew. And I think that's a really important point, is that, you know, whilst our funding has been capped at that 2.592, there's 4.5 billion sitting in that PCN budgets, those local budgets. So it is about mobilising locally in terms of what we can do to try and access some of that money, working to that collaboratively, fostering those local working relationships, and trying to really maximise on that funding that's sat there.
Yeah, if you're an independent prescriber, the last thing you want to be doing is putting labels on boxes. So if we're actually going to engage with the primary care networks and use the untapped potential of independent prescribers who are basically working as community pharmacists, we need to give them an opportunity to do that. In an LPC meeting just recently, I said, how many of you would rather dispense prescriptions or see patients? And every single one. And there are a lot of employees from the multiples also put their hands up. That's what pharmacists want to do that are out there. They don't want to be wasting the time dispensing prescriptions. We need to grapple with this, and we need to answer that question.
And the way to do that, Gary, I think you've hit the nail on the head. The PCNs are the key for this. So, you know, I can remember many years ago being in a meeting with the BMA, and the then chairman was a chap called Lawrence Buckman, and he looked at me and he said, I can work with you, but I can't work with Tesco. And that's where that local relationship comes into play. So Rena, independent prescriber, Gary, you're about to do it. I'm currently a prescriber. We have those relationships and the trust with our local prescribers, local GPs. So they'll come to us. So my local GP, she's now single-handed, just through retirement. And we prescribe for her using her practice budget. We do all the hospital letters, we do the queries, and she loves that. Would she do that if it was a pharmacist she didn't know? I don't think she would. It's a trust.
Yeah. One of my partners, I'm basically a partner in a practice as well. They just don't do corporates. I don't want to talk to some jobbing pharmacist who's going to be here today and gone tomorrow. I've had that said to me by numerous GP colleagues. This is a big opportunity for independence. There is no future in dispensing, but there's plenty of future in delivery of clinical services through bricks and mortar pharmacies.
Brilliant, thank you for that. We actually have quite a few people still on the line. Now, we were due to finish at 8:30, but if people are still on the line, I might just ask one or two more questions, if that's okay with you, if we keep going just for 5-10 minutes,
Okay.
whilst we will have you on here. And if people start to drop off, then I can let you know, and we can maybe call it a night. Just on that point, Gary, we've had a question around, if the GPs are head of PCNs, how would you ensure that pharmacies which are ready to offer the services will actually get a chance to offer them? For example, some GPs don't like us doing the flu jabs, and this is a really important point. We get this a lot around the difficulty some of our members have faced in trying to get GPs to accept that they do flu jobs. So how can we make sure that they will share other services with us?
Well, it's a conversation we've already had with NHS England, and the network DARES. I saw an article in Pulse the other day, which sprang it on the GPs that actually, although you're going to be at the core of a primary care network, it's not going to be your party alone. And the NHS England have already made it clear to the BMA, the GPC, that there will be a requirement to engage with other providers in the primary care network. So primary care isn't synonymous with general practice, at least not in NHS England's book. Now, there may be some GPs that choose to continue to believe that, but believe me, NHS England holds the whip hand, just like they do with us. They also hold the whip hand with the GPs, and there are already been suggestions that, that primary care networks that don't deliver the goods in terms of engaging with other contractors may well find themselves losing out financially. So, and also we haven't actually seen the new network DES, which will be implemented from next April. But our understanding is that that DES will require PCNs to engage with community pharmacies, dentists and optometrists across the entire primary care estate. So I don't think they're going to be given a choice in the matter. And even if they did have a choice, at the end of the day, the stuff that, like Andy said earlier, they won't be able to deliver it on their own. They can't deliver health checks. They can't screen large numbers of patients for atrial fibrillation. It's just not possible, because we've got the touch points, we've got the footfall that the GPs don't have.
And the capacity as well, Gary, because what the GPs are struggling with now is capacity, and whether that capacity is just workforce remains to be seen. It's actually the premises as well. So using, and as Gary and his team did in Jaunty Springs, using the pharmacy premises is really important. So GP practices, most of them are bursting at the seams. Then you add in social prescribers and various nurses and ambulance staff and all the rest of all these people who are coming in to help. We can do a lot from our own premises, and certainly using IT as Gary did. So connections, which you can do very, very easily. It's just a laptop. Into the GP clinical system is something that's open to everybody at a local level.
And I think we might be seeing more of that in the future anyway, won't we, Mark, with the futures, NHS Futures IT, in terms of opening up GP systems and allowing pharmacies to potentially access that. So I know that even at the NPA, we're looking at potential digital solutions to help pharmacies and enable that functionality in the future. So I think that will become easier.
It will. And just to go back to that question, how do we kind of stop the GP antipathy towards pharmacy services? Well, it's doing things that help them, and it's difficult for us when we're doing things that are in competition with GPs, but when you're doing things that they don't want to do, it's really useful. So one of our local practices has completely stopped doing travel vaccines because they just haven't got the nurse capacity. Most practice nurses, the large proportion of them are over 55, and they'll be retiring. So what happens there? There aren't enough of them as it stands. So when they start retiring off like doctors, they're going to have to give the work up. So it's great. We get people coming in all the time for travel vaccines because practice don't do them anymore. And there's loads of examples like that, things that they'll just stop doing. Minor ailments being a particularly good one.
Okay, and another question that I'm going to just put to you as well. I'm 100% behind the direction of travel, but I have two huge concerns. One, how will I pay my bills? And two, the sheer workload.
Right. Well, we've talked about skill mix earlier on. I think there's one other thing that's on the horizon, which is changes to the rules on supervision. Now, that's again is a really contentious issue for community pharmacies. because we worry that would allow a community pharmacy to work without a community pharmacist. But if you read between the lines, like Rena said earlier, and you actually look at the direction of travel, what's the point sending patients to a community pharmacy if there's no pharmacist there in the first place? The idea of the relaxation of the rules on supervision is about trying to encourage community pharmacists to let go of the dispensing operation to a team of suitably qualified and competent GPHC registrants, so that they can manage the dispensing operation and even deliver some clinical services themselves to free up time in order to deliver more care. There is one other thing which Mike Dent has also touched on in the roadshows, and that is around changes to the funding mechanism. Mark mentioned it earlier on, and if we move to a different funding mechanism where a community pharmacy can receive the same amount of funding and dispense less often to a patient through what we call flexing period of treatment, that will solve a lot of the workload issues that community pharmacies have got without cutting funding, and at the same time free up capacity. And that's another area, in addition to hub and spoke, that we need to explore with the Majesty's government. And so, but it does require changes to funding delivery mechanisms, and again, that's an area that's currently been looked at and explored. So whilst I recognise that there's a cost issue involved in all of this, again, you need to sit back and take a look at the bigger picture and ask yourself the question as to whether or not in some instances we need to dispense every 28 days to every single patient. And I think you'll find the answer to that is, in all probability, no. For example, patients on thyroxine, for example, why would you could dispense, in theory, you could dispense 6 months supply and it wouldn't matter one job. So there is a wastage issue, and it's something that's got to be carefully managed, and it needs a lot of thought and a lot of modelling, so we anticipate unintended consequences. But these are the sorts of things that we're going to have to tackle over the next 5 years. So as I've been telling my colleagues, this is a transformational deal, and we do need to change the way we operate in order to ensure that we can deliver what the government want within the flat cash sum. So that's a challenge, right? I might also add, there's one other point, which again has come across in the roadshows, and this is the fact that we've built in a review mechanism. So if at some point we find that our costs are escalating at a rate that we can no longer cope with, then we've got the opportunity to go back to the government and say, we do need more investment in order to make this continue to work. However, that clause within the contract document is also a two-way ticket. If we fail to deliver, it does allow the Treasury to go back in and unpick the deal. So there is a threat, and the threat of the counterfactual, which I've mentioned earlier on, still sits there if we're unable to deliver the government's agenda.
Thanks, Gary, and thank you for clarifying that, Graham. I actually lost the last bit of your question, which was actually around, so where he said the sheer workload, what he meant was in terms of the sheer workload and complexity of all the changes coming is bewildering and overwhelming. And I'm just going to put that to you, Rena, because I know that we've had conversations on a similar vein. So what would you say about that?
I have every sympathy with you. I'm in exactly the same boat. My advice is to break it down, which is what I've done. I've read through the documents, made about 6 to-do lists that I will cry at when I look at them every time. But break the tasks down, follow the PSNC timelines and timeframes that they're giving out. The MPA is there to support you all the way. Anything you're not sure of, please do get in touch with the MPA. This is a series of webinars that is out there, supporting our members because we realise what a struggle this is for all of us. Delegate some of the tasks. So if you have a pre-reg, the audits are a great thing for pre-regs to do. Dispensers can do patient safety work. I've got one of my dispensers training up to do all the patient safety reports that I spend every month doing diligently. Can be easily done by one of my dispensers. Really thinking about that workload. It shouldn't just be on our head. What should be in our head is understanding it and what needs doing, and then we have to get better at delegating. It's something we're not very good at. Most of us as independents are control freaks. Want to do everything. And I am guilty of that myself, and I've just realised I can't physically do it, so I'm going to have to let go of this and delegate and supervise and oversee, And that would be my biggest advice, because yes, the workload is immense and the rate and pace of change is immense. And moving a goalpost with the MURs, for example, all of these things are just hitting us every day. You open your email and see another email from Pierce and see another email from somebody else telling you to do something differently, and it is really, really tough. But use the MPA to support you.
Absolutely, and I would say to anyone watching this that in terms of our members, please do get in touch with anything that you feel that would be helpful to you. We are have all of our ears open, and as I said, we are busy producing, generating resources that will help you in terms of timelines and what needs to be done by when, to ensure that you don't miss any of those crucial dates. But if you feel that there is something that we could do to help you that we aren't doing at the moment, please do get in touch with us, and we will endeavour to deliver. On that note, it's now 8:45, so I'm going to suggest that we do wrap up unless there are any further comments from the panellists. No?
Hang in there is my only advice to all the independents. Hang in there.
Thanks, Rena. And thank you everyone for joining us this evening, both our panellists and our audience. It's been a really great webinar. I think we've taken away a lot in terms of what we could be doing right now. Certainly one of the biggest things we can tell you to take away is to read that document and start pulling it apart and breaking it down as Rena and Mark have suggested. Thank you very much, and if there is any further advice and support that you require, our pharmacy services team is available. That's the contact details. Please do get in touch, and thank you very much for joining us.